Good, after, good afternoon. First, I want to thank organizing committee for inviting me for this very prestigious webinar and meeting. My topic of presentation is cognitive function assessment in mild and moderate head injuries using the MOCA score. We all understand that traumatic brain injury is a major public health problem and it is increasing day by day, and it causes a lot of morbidity and mortality, and it surpassed number of diseases by 2020. And India and in any developing country, the incidence of increasing because of transportation, industrialization, change in social values, construction of industries, and etc. In cognitive impairment is one of the most important culprit which influence the neurological outcome in TBI survivors. So TBI cause cognitive deficit which interfere with work, activity, daily living, relationship, social imaging, and it caused a lot of economic burden on society and nation both. There are a lot of literature available for cognitive deficit in severe and moderate head injuries in form of executive function, attention, concentration, and information processing speed impairment. But for mild and moderate, it is very less. India and all low-income countries, because of overburden in mild and moderate head injuries, they are usually neglected or undertreated. So there should be a strong system for evaluation of the TBI cognitive function in mild and moderate head injury. Although there is a lot of development in TBI rehabilitation in India and developing countries, but compared to Western, still we are in very infancy level. So looking to all these problems, we decided to have a project in our department about the assessment of cognitive function in mild and moderate head injury. And for this, we use the GCS, the scale for the assessment of the cognitive function and education. And in this mild, the 127 cases were there. In moderate, there were 101 cases. These are the exclusion criteria of patients. So all the patients were evaluated while they were awake, cooperative, and they were taken to our this department. And this is a department right now, rehabilitation department in the middle of our department, and help lot of patients for the rehabilitation. And cutoff less than 26 was taken as a impairment of the MOGA cognitive impairment. This is a Montreal cognitive assessment score, which was first given by Jedal in 1996, and now about 46 in 46 languages this scale is available, and it takes 10 minutes. It has 30 score and 12 subpoints and 7 cognitive function major headings. And it has been proved that as per the MASS scale, it can tell about the this senile dementia better and earlier than MASS scale. So it is very famous and adopted by a number of countries. So this is all of our work which has been published as well. So aim of our project was to investigate profile of cognitive impairment in mild and moderate traumatic brain injury using Montreal scale. And first we diagnose by fastest mean and then how to improve these patients regarding their quality and entry to the society. So all results were analyzed statistically. So when we analyze, we have seen that in mild TBI, MOCA score average was 20, while in moderate it was 18. And mean score performed by moderate TBI group was low in all subset compared to mild TBI. There was a significant difference observed among the mild and moderate TBI. And as far as the clock, visuospatial, executive function, digital span test, and recall, there was all found statistically significant. As far as the imaging is concerned, unilateral lesions, particularly in right frontal location, were more common, while in moderate, bilateral and diffuse lesions were more common. While in temporal, parietal, and capsulogonic lesion, there was no statistical difference was seen in both the groups. For our in our patient, the range was 12 to 30 in our patient, and for our convenience, we divided our patient in 4 groups: G1, G2, G3, and G4. And in G4, we don't had any patient in our series. So when we analyzed, we found that patient belonged to G3 group had a poor performance, and G2 performed statistically proven low score in all subsets of the scale, while digital span, serial subtraction, orientation were not found statistically significant. MoCA score was found higher, where high GCS was very high, because GCS we took the criteria for level of consciousness and neurological status. In mild type of variety, most of the patients were in G2, 43%, while in moderate, most of the patients were in G3, around 54.5%. While in this moderate group, G2 and G1 were 34 and 10.8% patient respectively, and it was found statistically significant. So when we compare, review the literature, we found there is a lot of contradiction, because the difference in severity, mild and moderate of injury was very less. And we found the review of literature such that Dickman studied 20 cases, and with the standard when compared, found that most of the patients, they improve within 1 month, while Camp in his big series found that most of the patients, they recover in 8-month period. So our result indicates that cognitive impairment is more extensive, severe in moderate TBI, especially for executive function, attention, concentration, memory, which might be the critical differentiating trend in cognitive impairment in both groups. Executive function, attention, concentration, and memory are the main domain of the MoCA score. And we also understand with our clinical experience as well that memory is one of the most important cognitive impairment after TBI, and it is first to lose and last to recover. When we know, seen the literature, we've seen that in cohort, most of the patient has frontal temporal lobe lesion, there they lead to impairment of the cognitive function. But in our study, as I mentioned before also, that moderate functions were were fall in imaging, where there was bilateral and diffuse lesions were found, while unilateral right frontal lesion were more seen in the mild type of the TBI. Education is very important, which correlated with MoCA score. We found that patient more than 12 years had significantly better score as compared to education level below 12. And in mild and moderate, it was a 40% and 50% respectively. So just I want to conclude that assessment of the cognitive impairment should be considered as a mandatory protocol while evaluating post-TBI patient, even in cases of mild TBI. MoCA's score assessment system is quick, reasonable, sensitive for TBI. Visuospatial, executive function, memory, attention are the most commonly important domain of this cognitive. It differentiates the mild and moderate head injury. Therefore, there should be quick and screening system on OPD basis which can evaluate this. After this, all the patient we need to rehabilitate. So, aim of rehabilitation is to enhancement of human functioning and quality of life, improving physical disability, enhance functioning and independence in the patient with cognitive impairment. So this is our department of neurorehabilitation. And so all the patients undergo neurological, neuropsychological, speech and occupational therapy evaluation. And when the patient is evaluated, then interdisciplinary team comes in play and they work hard for rehabilitation. So as far as the rehabilitation, cognitive behavior therapy, which has component of mood, anxiety, psychotic disorder, sleep disturbance, and chronic pain improvement, while the cognitive rehabilitation therapy, which is very important and different aspect of this is restorative. Restorative aim is improving, strengthening, or normalizing the specific impaired cognitive function, and it is done like exercise like, because then that particular aspect or part or which is deficient, there is intense and repetitive use of particular cognitive process for improvement. Compensatory treatment can be internal and external. For external, we can use the electronic reminder, while for the internal patient, if verbal is not, then written material can be used for this. Remediation approach is very important. Real world goal of CRT is to improve outcomes such as work, socialization, and independent living skills. And generally, it recover in 5 months, but it may take 7 months. Other part is self-awareness. Self-awareness, improving self-awareness is essential for improving other cognitive domain, as patient must first recognize their deficit to improve them. And it can be listed and it can be improved by video or verbal feedback, or one of the best protocol which we have, it's group based sessions where successful evidence based intervention that can improve self-awareness, and it's very successful in our department. Learning and memory, small amount of new information are presented at multiple short time period, and this is very successful. Executive function is ability to plan, organize, strategize, and focus attention. This is very important, and it has been seen that in mild type of TBI also executive function may derange. So there are the few of the pictures. This is our video. I want to share that with the help of this these games, we can improve the initiation, memory, skill, execution, decision, even the motor deficit power can be improved with the this type of exercises if done every day. So for this, we have the interns which comes and work for our patients. Attention is very important, which shown to improve selective attention in individual with TBI by progressively increasing attentional demand. Other important thing is cognitive orientation to occupational performance. So, which here we encourage the individual to use metacognitive strategy to identify and strengthen the weak area of cognition. It can be done by video conferencing or therapy, and it has been well proved in COVID period that video conferencing is very helpful for this patient. And if patient cannot improve verbal, then we can use the written information form if a patient can use these models. This is another the same patient video where Uh, these interns, our health workers are working in the morning time and help in initiation, execution, again memory, motor power, this is physiotherapy, and definitely it helps lot of our patients. Other is generalized strategies and approaches, which include aerobic exercise and music therapy. Aerobic therapy is associated with increased production of brain and derived neurotropic factor, which facilitate neurogenesis, while exercise we all know cause angiogenesis and increase blood flow to the brain and improve the um, executive functions. So they are the exercise models which we have, and this is very simple. I think all the uh, department of neurosurgery can afford these type of very basic instruments, and definitely it helps. And when patient require very specific type of exercise or models, then we refer to our higher department, which is right in our hospital. And but these all models are available in university department, and our resident junior staff are there, and they also develop interest, and this way the awareness of rehabilitation is also there. Music therapy based on therapy is also known to improve cognitive functioning by altering, restoring brain function. And music therapy improve executive function, mental flexibility, reduce anxiety and depression. And this is just recently published um, uh, on this February this year, that some neurons respond and to speech and music. So music therapy is very, very important part. Daily cognitive recognition of individual faces and objects can be improved by social interaction and by simulated models like ATM and all, and definitely it helps the patient. We know the age of accidents age group is usually adult, middle age, and they're very important part of the family. They're earning member. So entry to occupational therapy, so occupation or their job is very, very important. So occupational therapy is stabilized to select, tailor an evidence-based cognitive rehabilitation program for their patient in time efficient and effective manner. So he is our staff member who was there, and I met without traffic accident, but effort of our staff, with the effort of our staff, this patient was rejoined our department and working with us without any problem. Thank you very much.